Hello, I'm Adrian Gowdy, and in this lecture we're going to discuss vascular access techniques using ultrasound. So why bother using ultrasound at all? Well, it lets us see what we're about to try and target with our needle. It allows us the visualization of anatomy both before and during the procedures, and that helps us better localize where the structures are. It helps us detect abnormal anatomy that we might not otherwise suspect. And one of the things that I think is underrated is that it can help prevent us from attempting procedures which have no chance of success, such as trying to cannulate a thrombosed vein that you didn't realize was thrombosed. There have been a number of studies performed on the use of ultrasound for central venous access, and the meta-analysis of this suggests that overall there is a higher success rate, there is a lower complication rate, and you require fewer attempts for success. Some people, however, do disagree, and certainly I don't think it's unreasonable to expect that somebody who is very experienced at placing central lines without ultrasound may still be better than somebody who is a novice but does use ultrasound. Overall, it is probably not faster because you have to set up the machine, it's a bit more fiddly, there's more equipment. But the group of patients where it really helps are those that are difficult. Patients don't always read the anatomy books, and what we assume is going to be the anatomy when we do the landmark technique may not actually be present. For example, looking at the internal jugular vein, in 54% they will overlie the carotid to some extent. And in 8% of patients, they've been described as being small, unresponsive to Valsalva, or to have an unexpected relation to the carotid. If we look at the femoral vein and artery, we all assume that it's going to be nerve artery vein, all lying in one horizontal plane. But in actual fact, at the point where we would normally put our needle in 2/3 of patients, there is at least some degree of overlap in the anteroposterior plane. And to get that position where they lie side by side, you often have to go a little bit more proximal. And so what we can do is use ultrasound to have a look first at the anatomy in all the potential sites that we might use. And by doing that, we can then select the site that's most likely to be successful and is going to be the easiest for us to perform. Now, when we use ultrasound, there's a few decisions we have to make. The first is, do we use the ultrasound to actually watch the needle go in? That's called direct visualization, sometimes referred to as the dynamic technique. The first possibility is that we can just use the machine to have a look at the anatomy. We can mark the skin to help work so that we know when the patient's fully prepared exactly where the vessel is, and then we put the machine away and we proceed as if we were doing a landmark technique. The more complicated but more accurate method is to actually watch the needle. Now, if you're doing a procedure that requires both your hands, you may even need another person to hold the probe for you. It is more difficult, it takes more coordination, and one of the things you've got to learn to do is to watch the screen, not watch where the needle is, because you need to see the needle on the screen. If you do decide to use direct visualization, then there's another choice that you have to make. Which way do you orientate your transducer? Do you have it in line with the vessel and in line with the needle, and that's referred to as the in-plane technique? This gives you much better localization of the needle tip, but it does take more coordination because you have to keep everything in the same plane. The out-of-plane technique, where your beam will go across the needle, is easier. Often the transducer will fit, in particular if you're looking at, say, a groin crease, so the transducer size is not as much of a problem. But the biggest drawback is you have to be very careful to make sure that you're not sliding up the shaft of the needle and not missing where the tip of the needle is. So to show you what these approaches are, this is an in-plane approach. This is a tissue phantom. Here's our target vessel here. and we see the whole needle coming down. We see exactly where the tip is. In the outer plane orientation, here is our target vessel. Crosswise, you'll see a little bit of tissue movement, and then you see the needle tip, some movement, the needle tip. I'm sliding the probe forward as I do this so that I keep an eye on exactly where the tip is. We see a little bit of tenting, and then we enter the vessel. But as I've mentioned, the biggest problem is that if you let the tip go a little bit too far, or you fail to see it, what you might wind up with is a beautiful image on the screen, thinking that your needle is right in the middle of the vessel, whereas in fact your tip has gone too far. And if there's something down here that you were trying very hard not to hit, well, you might have just caused a disaster. So, setting up the machine, you need to choose the right preset. And what you want is the one that will show the needle best of all. Musculoskeletal settings are often good. A lot of machines have breast settings that are designed for use for biopsies, and they are often very good. You need to just try your machine until you find which one works best. If you've got an adjustable focus, often having that near the top of the screen will help show the needle very clearly as well. The difficulty for the machine is increased as you increase the angle of your needle, because the steeper your needle, the fewer reflections will actually bounce back towards the probe. Now, of course, the position of the target may determine how steep your angle of approach has to be. But in those cases where you're really struggling to see the needle, then sometimes looking for tissue movement as you jiggle or slowly advance the needle will often help show you where your needle is. But of course, again, you then have difficulty working out where the tip is. So this diagram shows that in this sort of approach where the needle is fairly flat, you're going to get a lot of reflections coming back to the probe, so the machine should pick that up quite nicely. With a steep angle attack, however, a lot of that energy is going to hit the needle and bounce off in this direction here and not come back to the probe. So it's much more difficult for the machine to find and display that needle. Just like any procedure, you need to prepare everything before as much as possible. So what we use is a cover for the probe. If it's a sterile technique, for example a central line, then we'll use a sterile probe cover. We will put some gel inside the probe bag or onto the probe, which we then cover with the bag. That doesn't have to be sterile. And then outside we'll use sterile gel, or we can use antiseptic solution as a contact medium. You can even use just sterile water. The plastic sheaths, most departments should have these available now. If you're doing a fully sterile procedure, you need a long plastic sheath so that your cable is also covered and that doesn't disrupt your sterile field. You can use a sterile glove, but first of all, they're quite short, and secondly, the fingers tend to flop back and get in the way, and they've often got air in them. You can use an adherent dressing. That tends to work well, but if you're going to do that, make sure you put some gel over the end of the probe before you put the dressing over. Otherwise, when you take the dressing off, you might rip out the rubber cover that sits on top of all the crystals, and then you need to buy a new probe. You need to make sure that what you're looking at is actually a vein, or, unless you're doing an arterial cannulation, an artery. The best way to tell is to use pressure. Veins should collapse. You can compress arteries, but you have to press an awful lot harder. And if your vein doesn't collapse, then it's thrombosed and you probably need to find another target anyway. Don't forget, central veins do have central venous pulsations. It may be a double pulsation if the patient's in sinus rhythm. In particular, if you've got a patient with tricuspid regurgitation, the pulsatility of the vein can be very marked as well. And so we don't usually use that as a discriminating feature. You can use spectral Doppler if you're really unsure, but my advice would be, if you're that unsure, you probably shouldn't be trying to stick a big needle in there anyway. When you're selecting the site to approach from, try and make sure that, if at all possible, your target vein in this case isn't overlying something that you don't want to hit. So for example, in this situation here, if I inadvertently go too far with my needle, I'm going to hit the artery. So in this case, what I'd do is I'd get the patient to turn their head to the left more. I'd swing my probe and needle around here to the right to try and get this sort of approach, so that if I do inadvertently go through the vein here, I'm not going to hit my artery or any other hopefully critical structure. Like everything that you do, try and make things as easy for yourself as possible. So in terms of venous cannulation, reverse Trendelenburg, paddock pressure, peripheral veins, use a tourniquet, whatever you can to try and get the target as big as possible. It also increases the pressure on them, which makes it easier to puncture the vessel with your needle. Now, in particular, if you're using an in-plane technique, sometimes what will happen is you will lose your needle. You'll be looking on the screen, you've got your target vessel, but you can't find where the needle is. And in this case, especially for beginners, there's often a tendency to hold the probe still because it's showing your target, and then try and move your needle around until you see it. But the whole point of using ultrasound is we're trying to avoid just jabbing the needle around. So in that case, if you do lose your needle, hold the needle still and move the probe until you find the needle. And at that point, what I'll do is I'll switch back and forth between the needle and the probe until I've got a really good idea in my head that, for example, the needle's a bit medial, target's a bit lateral, bit medial, bit lateral. So I know I need to withdraw my needle, move it more laterally, angle it a little bit, and then re-advance it. If you really can't find your needle, then change to an outer plane orientation until you find it. It'll give you a broader area to look through. So then you can find your needle, and once you've found it, you can then reorientate it and change back to an in-plane technique again. It takes practice to do this and to learn to change between the different orientations. It's a physical skill. Often what you'll see is that you'll get your needle sitting right on top of the vessel, but you can sometimes have trouble puncturing the vessel. Veins are collapsible, and sometimes they even collapse and move out the way a little bit. So try and get your needle right over the middle of the vessel. You'll often see tenting as the needle's about to puncture, and at that point I'd suggest a short sharp movement to try and puncture the wall. If you're using for a central cannulation, try and time it with respiration, so that as the vein expands when it's got its greatest pressure, then you advance it. So that will be with expiration in a spontaneously breathing patient, or with inspiration if they're positive pressure ventilation. Different people actually suggest different things with the angle of approach. Some people suggest trying to flatten your angle so that you don't compress the vein as much, or to increase the angle so it's quite steep, to try and just push through the vessel wall at that point. Unfortunately, sometimes you may actually compress the vein fully before the needle goes through. And this is why sometimes you'll only get a flashback if you're doing a landmark technique as you withdraw the needle, because you've actually gone all the way through. However, the whole idea of ultrasound is that we try and avoid doing this. So try and line it up, time it, particularly with respiration, so that you'll actually puncture just one wall and get into the lumen. So let's talk about some of the specific sites that we might use ultrasound for central venous access. First of all, the internal jugular vein. This is probably the easiest site to use ultrasound for. Just to remind everybody of the anatomy, here is our carotid artery here, and lying lateral is the internal jugular vein. This is a recording from a patient who had quite severe pneumonia. He was a very large man, about 130, 140 kilos. He was quite dyspneic, and we can see the changes in the size of the jugular vein associated with respiration in this patient. The only vascular access that could be obtained was a 22 gauge in the back of his thumb, and it was felt that this was inadequate because he was struggling, and we thought he may well tire and deteriorate. So initially we thought we would avoid any area around the chest and went to look at his groin. Unfortunately, under the rolls of fat, he had a significant degree of intertrigo, and we thought we could not possibly put a central line through an infected area. So we came back to the internal jugular vein. And this was certainly an example of the type of access that I would not attempt without having ultrasound to guide me. And in fact, what we managed to do was we prepped the patient, we put local anaesthetic in whilst he was sitting up, and when everything was ready, we then lay him back as far as he could. We got somebody to push into his right upper quadrant, and we tried to elevate his legs a little bit to try and fill that vein as much as possible while we did the actual insertion. All the needle advancement was done as the patient breathed out every time. Every time he inspired, we just stopped and waited, and we managed to get the wire in. We then got the triple lumen central line in, and then managed to sit him up, surprisingly without any complications, and I'm pleased to say it was easier than we had expected. But as I said, this is the kind of thing that I don't think you should attempt unless you've got a tool to show you exactly where your needle's going and what is happening with your target. Now here in this loop, what we can see is here is a needle here. This is an in-plane technique, and this is the local anaesthetic needle. You'll see as we inject the local anaesthetic and we draw the needle, and this is a short clip, and you'll see the needle come down and just puncture the vessel here. So it comes through, there's the tip just sitting there. The loop keeps replaying. We didn't actually keep jabbing it in and out. And at that point, we put the probe down, we feed our wire in. I usually use the machine to check that the wire has fed down the correct vessel before I put the dilator down, just to be absolutely sure that I'm in the vein, not the artery. And then we proceed as normal without the ultrasound machine. Once it's in, I will then use the ultrasound machine to again check the position of the catheter and also to look for a pneumothorax. But that's beyond the scope of discussion of this lecture. If we look at the femoral vein, we normally look at the midpoint of the inguinal ligament. We have the nerve, the artery, the vein in their normal expected relationship. Here we have the nerve, the artery, the vein. Here we have the inguinal ligament. But as I mentioned, the artery divides into the profunda branch and the superficial femoral artery, as does the vein, just around this point. And at that point, the four vessels, instead of lying horizontally, rotate so that they then come to lie in a perpendicular plane. So sometimes you actually have to aim a little more proximally to get that side-by-side relationship. Here we can see, with a little bit of pressure, we can see the vein collapse, the artery doesn't, so that way I know that this is the vessel I'm aiming for. Now the subclavian vein, you can use ultrasound to assist in placement, but it is technically the most difficult one to do. So I wouldn't suggest you try this until you're very confident with placement in the other sites first. If you do want to view the subclavian vein, start more laterally around the deltopectoral groove and then slide your probe in medially towards the clavicle. Here, reminding us of the anatomy, we have the clavicle here we have the vein, and here we have the artery. This is from a CT, just to remind, this is a coronal section. We have the clavicle, under it lies the vein and the artery. So, we start off at the deltopectoral groove, we see the vein here, and we see the artery. I compress, and especially young blokes who've got big pectoral muscles, you have to press quite hard to compress, but that confirms and reassures me that this is the vein and this is the artery. I then will turn onto an in-plane view and I will trace the vein up in that plane. Here I'm tilting up towards the head, so I'm angling up under the clavicle to show the relationship between the vein and then the artery, lying more superiorly. Once I'm absolutely certain I've got the vein, I will then trace it up towards the chest, medially, and we can just see on that clip the clavicle shadowing coming in at the end. This is the final image from that clip. Here we have the vein, here we have the clavicle, and this is the position that I will hold my probe in order to then bring my needle in. I want to see my needle come in at this angle here to aim to puncture the vein just around here or just near where it dives in under the clavicle. It is more difficult. You are at a bit of an angle. The clavicle does get in the way. You do tend to have a more lateral entry point than you might do otherwise, but certainly you can use ultrasound for this. Now, don't forget, ultrasound actually can be very, very useful as well for peripheral lines, in particular for patients who have very poor peripheral access, such as intravenous drug users, some of the oncology patients, and patients who've needed long-term antibiotics for various reasons. Generally, we look for the basilic or the cephalic vein in the forearm, up around the elbow, or in the distal arm. And if you are going for these veins, they are generally going to be a little bit deeper. If they weren't, you wouldn't be using ultrasound. And so it's well worthwhile using a longer than normal cannula, because otherwise the short cannulas will tend to fall out. So here is a diagram that shows the anatomy of the upper arm, and a couple of points are worth noting. Adjacent to the brachial artery are the two vena comitantes. They are normally smaller than the more superficial veins, the cephalic and the basilic, but in some patients they may be the largest veins in the arm. But they are very close to the artery, and the other thing to remember is that the median nerve sits adjacent to the artery as well. And so these are two structures that you want to avoid, so going for these as your target vessels is more complicated than going for the more superficial vessels. Here to show you, this is a scan. We have the artery here, we have the vena comitantes here, and here we have the median nerve. And in this situation, this here is a much bigger, more superficial vein, and this would certainly be my target here rather than the smaller vena comitantes in this situation. This shows where I'm scanning, and I will scan up and down the arm until I find a target that is big as possible, nearest the surface as possible, and as far away from other structures that I want to avoid hitting as possible. And weighing all those things up, I will then decide on which target I'm going to aim for. Here we just show that with compression the vein collapses, confirming that it is a patent vein. And a final diagram from a slightly different angle to show the artery, the vena comitantes, and in this case the basilic vein with the humerus down here. Now sometimes if you want to infuse large volumes quickly, these kits can be quite useful. You place a normal cannula into a vein, then you can feed a wire through and then put the dilator and sheath over the top in a Seldinger type technique, and these will allow the rapid infusion of large volumes very quickly. One thing to remember though is that the length is not the same length as a central venous sheath, and therefore you do have to be a little bit careful if you're placing them into very deep veins. So I generally wouldn't use this sort of kit, for example, with a femoral vein, but for a peripheral vein I will do. So to complete, what I want to do is run over some practical tips for success, and to go over things that I have seen trainees struggle with, and to try and help suggest to you ways to try and improve your success rates, especially when you're starting out. Now, one of the things that I notice quite often is that when people are in workshops and after the lectures they go to the practical stations with the phantoms, and they often find that they regard it as quite an easy technique. They have a very high success rate straight up. They then go back to a real patient and try, and suddenly it's not so easy. So what's the difference? Well, one of the important things I think is that when you're working on a phantom, then you will automatically place the phantom and yourself so that everything lines up. By that I mean your eye, your hand, the needle, the target, and the screen that you're watching the image on will all be in the same line. And when you do that, you'll find automatically that the direction of the needle, the direction of the probe, and everything else is all in the same line. However, when you come to real life with a patient, they're on a trolley. You might not be able to move them as easily. You've got an IV trolley next to you. The machine has to be manoeuvred into a place where it will fit. And suddenly, you're in this situation. You're standing here, you've got your head turned one way looking at the screen while your hand's trying to push in an opposite direction towards your target vessel. And suddenly, you find that you lose your needle. Things don't line up. And so my strong suggestion is that as much as possible, try and get things to line up with the patient, your target, the screen, all in a line as much as possible, and you'll find that your success rates are much higher. Now, the next point I want to go through is when you're doing an out-of-plane technique. As we mentioned earlier, the biggest problem with this technique is that you may have your beam cutting through the needle shaft and the needle tip may be a lot further down than you expect. And although you get a nice picture on the screen and you think you know where you are, in actual fact your tip's down a lot deeper, maybe doing some damage. And so the way I avoid that happening is to alternate moving between the needle and the beam so that I alternately see the tip and then lose it. And that way I know I'm dealing exactly with the tip. What do I mean by this? Well, for example, here we have a vessel, and in this case I would have scanned up and down, and let's say for example I decide I want to target the vessel at this point here. So I want my needle coming in and hitting here. I judge the depth of the vessel. I work out, all right, for the needle to go into the vessel here, I need to actually puncture the skin a little bit this way to give myself enough room for the needle to travel down. So I will bring the needle back, I will puncture the skin and go just beneath the skin, just feel the pop through the basement membrane. And at that point I hold the needle still and I will slide my probe back up over the point where it's gone through the skin until I can just see the needle tip on the screen. Now at that point I still hold the needle still. I do not advance it yet. I will then move my probe forward, and this can be either sliding the probe forward or tilting it so that the ultrasound beam moves more forward, and I will do that until I lose the tip. So I can no longer see the tip. At that point I will then hold the probe still. I will then advance the needle until the tip of the needle just enters the ultrasound beam. And I'll do this, I normally aim to move the ultrasound beam about 2 to 3 millimeters forward in each of these cycles that I do this. So I've moved the probe forward, I no longer see the tip, I now hold the probe still and I slowly advance the needle. And I advance the needle until the tip appears. And at the instant the tip appears, I stop moving the needle. I then hold the needle still, and once again I will move the ultrasound beam forward, either by sliding or by tilting it a little bit, until the beam comes off the tip of the needle and I no longer can see the tip on the screen. I then hold the beam still, hold the probe still, and advance the needle until once again I see the needle tip just appear on the screen. And at that point I stop moving the needle. And I will do this with the idea that I will see the tip walking down essentially right onto the top of the vessel where I want to puncture it. And as I do that, if I see that my tip is going off to one side, well then I can swing the direction of the hub of the needle around so that when I advance it, it will start moving back towards where I want it to puncture. I can also judge whether I'm coming in on too flat or too steep an angle by how much further down the needle tip appears. If every time I do this the needle tip really isn't appearing any deeper, then I know I need to lift my hand up and increase the angle of approach of my needle so that I can see it walk down. And as I said, I would normally expect to gain about 2 or 3 millimeters every time I do this. So for example, if my vessel is 1 centimeter deep, then I would expect 3 or 4 cycles of this alternating movements between the beam and the needle until I get to the point where the needle tip is resting right on top of the vessel. And at that point, I'll give a short, sharp jab to try and puncture the vessel. If I'm doing a central access, then I will time that puncture with respiration so that my target vessel is at its maximal size with the maximal pressure as I try and puncture it. I think this is a very important concept and technique to get embedded so that you don't have the situation where you think your needle still has to be advanced to hit your vessel, whereas in fact the tip is much, much further down. So please, in the practical stations, make sure you practice this. Finally, I also find that my success rate's much greater if I can have the beam in a perpendicular plane. If it's perpendicular, especially if I'm doing an in-plane technique, then I find that the chances of my needle appearing and being able to have my needle all the way down the beam of the ultrasound and therefore appearing on the screen is much greater. Now, the thing is though that unconsciously, in order to get a really nice picture of my vessel, I'll sometimes actually move the probe a little bit to get a clearer picture. But if I do that, and for example, if I'm on the neck and I'm sliding around to the side of the neck, then suddenly I'm on an angle here. And lining up the shaft of the needle along the plane of the beam is much more difficult. Well, I certainly find it more difficult if my probe is on a funny angle, because my brain and my eye will try very much to keep things in a perpendicular plane. And so I'll puncture the skin here and I'll advance my needle. If you can imagine, if this is an in-plane technique, the needle shaft will go from here down to here, except of course it won't be lining up on the vessel and I won't see it on the screen because it's now out of the ultrasound path. And so as part of my preparation with trying to line up the machine screen, my target, my hand, my eye, the other thing I try and do is have all of these things perpendicular. And certainly I find if I do manage to get everything lined up well and I'm in a perpendicular plane, then I know I've got a very high chance of the needle appearing on the screen, being able to watch the tip go down and have it puncture my target without any hassles. I also know that if I'm on a funny angle, if I can't get things lined up, then my chance of success on that first pass without difficulty are much, much less, and I'm likely to struggle on that situation. So try and make sure as much as you can that you get all these things lined up. You'll certainly find it helps your success rates, particularly early on. So at this point, that's the end of the lecture. We're going to go into the practical area. We're going to use the tissue phantoms and we're going to practice all those techniques. Remember, this is a physical skill. The only way to learn how to do these things is to practice. So practice on the phantoms first. Once you're good at the phantoms, then practice on peripheral veins. Because if you can get a cannula into a deep peripheral vein that's 3 or 4 millimeters in diameter and know exactly where you're going, then you'll actually find that putting a needle into a much bigger central vein that's 12, 13 millimeter size is actually quite simple. And while you're learning, nobody's going to get too upset if you accidentally go a little bit too deep on a peripheral vein. Whereas if you go too deep while you're going for a central vein, you might cause a lot more problems. Thank you very much.